Welcome back to another Rapid Fire Explainer. We heard you loud and clear. By popular demand, today we're keeping things strictly focused on high-yield ATI and NCLEX-style questions and answers. We're literally taking the core concepts straight from the pediatric textbook and flipping them into an active recall study session. And today's focus, the child's experience of hospitalization. Let's get into it.
Okay, so here's our quick roadmap for today. We're going to hit separation anxiety stages, assessing infant pain, minimizing hospital anxiety, recognizing pediatric regression, reversing sedative overdoses, and then wrap it all up with a critical thinking challenge.
Starting right off with Section 1, Separation Anxiety Stages.
All right, here's your very first question straight from the source material. I really want you to actively engage here, okay? Take a quick second and lock in your answer. What are the specific stages of separation anxiety in the toddler?
Take a look at these options. I want you to think about the exact chronological progression a toddler goes through when they're separated from their primary caregiver on a hospital setting. Which of these sequences is actually clinically accurate? Protest, despair, and denial? Denial, dependence, and submission? Protest, sadness, and despair? Or despair, anxiety, and regression?
If you guessed option 1, you hit the nail on the head. This illustrates exactly how the textbook breaks it all down. You see, a toddler doesn't just immediately give up. They start off in the protest stage, right? That means loud crying, calling out, actively resisting strangers. Then, as the exhaustion really sets in, they shift into despair. They get quiet, withdrawn, maybe a bit depressed. And finally, they hit the absolute most dangerous stage, denial, which is also known as detachment. This is tricky because they might look like they've settled in, but they're actually repressing their feelings. They might even completely ignore their parents when they visit, which is a huge red flag.
Moving right along to Section 2, Assessing Infant Pain.
Now, think about your daily nursing assessments on the floor. How do we scientifically and objectively evaluate pain in an infant who literally cannot speak to us? The question asks, the nurse understands that pain in infants, what?
Okay, let's eliminate some distractors here. Options 1 and 2, we can toss those out immediately. Historically, there was this awful misconception that infants didn't really process or remember pain because of quote-unquote immature nervous systems. But modern nursing evidence has totally debunked that. Now, option 4 is a bit of a trick. Sure, fear plays a role, but it doesn't actually cause the physical pain. So, by process of elimination, that leaves us with option 3. It can be assessed by observation of behavior.
And here's the why behind that. By using validated tools like the NIF scale, that's the Neonatal Infant Pain Scale, we are strictly observing behaviors. We're looking closely at their facial expressions, checking for grimacing. We're assessing their cry, like is it just a whimper or are we hearing a vigorous, full-blown scream? We check their breathing patterns, and we see if their arms and legs are relaxed or rigidly flexed. By scoring these very specific behavioral cues, we take the guesswork out of it. We can objectively quantify and, more importantly, treat that infant's pain.
Up next is Section 3, Minimizing Hospital Anxiety.
I want you to put yourself right there in the hospital room. You've got a highly anxious, crying infant. What is your absolute best, evidence-based priority to minimize their separation anxiety?
Let's look at the options. Explain routines, encourage a parent to room in, age-appropriate roommates, or a toy. Well, while toys and distractions are absolutely great and keeping a routine helps, an infant just doesn't have the cognitive ability to grasp a verbal explanation of hospital routines, right? And having another baby as a roommate definitely isn't going to soothe them. So that makes option 2 the definitive high-yield answer. Our source text actually anchors this best practice perfectly. The absolute most effective intervention a nurse can facilitate here is preserving that vital parent-child bond. By strongly encouraging parents to room in, we essentially eliminate the physical separation that triggers that whole protest, despair, and denial cycle we talked about earlier. It's a total game changer.
Moving on, let's look at Section 4, Recognizing Pediatric Regression.
Okay, here is a classic NCLEX scenario. A 4-year-old hospitalized child wets his bed. The parents tell you, the nurse, that the child was completely toilet trained. It's testing your ability to distinguish a pathological issue from a completely normal hospital coping mechanism. So what should the nurse understand here? To nail this one, we really have to recognize the sheer impact of acute illness in the hospital environment itself. Are the parents in denial? Is the child delayed, regressing, or punishing the parents. While the child definitely isn't being malicious or trying to punish anyone, and there's absolutely no evidence of a long-term developmental delay based on just one acute incident. It's the intense stress of the hospitalization causing a temporary setback, which points us straight to option 3.
Regression is officially defined as the loss of an achieved level of functioning. Think about it. They've already mastered the potty chair, but under the severe stress of being in the hospital, they revert back to an earlier stage of development. So you see things like bedwetting, or maybe suddenly demanding a bottle. And the crucial nursing intervention here? It's all about education. We literally have to guide the parents to praise appropriate behavior and just completely ignore these temporary regressions. Whatever you do, you don't punish the child for it.
Let's ramp up the acuity a bit with Section 5, Reversing Sedative Overdoses. I want you to picture your emergency crash cart. Your pediatric patient's respiratory rate just dropped dangerously low right after a procedure. You need to act fast. What are the specific pharmacological antidotes you must have on hand for a reaction to or overdose of a narcotic or sedative?
Now, what makes this one extra spicy is that it's a select all that apply question, and we all know these can be notoriously tricky on the NCLEX. You've got naloxone, EMLA, flumazenil, and diazepam. This question requires you to map 2 specific antidotes from this list to the 2 exact drug classes mentioned in the prompt.
So options 1 and 3 are your winners here. Naloxone, commonly known as Narcan, is your direct reversal agent for opioids and narcotics like fentanyl or morphine. Then you have flumazenil, or Ramazacan, which is the specific reversal agent for sedatives. We're talking specifically about benzodiazepines here, like midazolam or diazepam. And hey, did you notice that diazepam was actually option 4 on that previous list? Total trap. That's the drug causing the problem, not the antidote. Oh, and EMLA? That's literally just a topical numbing cream, so cross that one right off.
Finally, we arrive at Section 6, our critical thinking challenge.
Let's dive in. A 5-year-old child hospitalized for 2 days is expressionless but not crying. The mother calls, stating the child seems adjusted and she won't visit to avoid upsetting her. How should the nurse interpret this? So ask yourself, is this child actually adjusted? Think all the way back to our very first question today. No way. This child is actually experiencing detachment, which is that final, most dangerous stage of separation anxiety we talked about. The mom is understandably misinterpreting the lack of crying as a good sign, but the reality is the child is emotionally shutting down. As the nurse, you absolutely must intervene here. You need to gently educate that mother that this is a stress coping mechanism, not true adjustment. You have to strongly encourage her to visit and room in to rebuild that vital bond. So, here's a thought to leave you with. Exactly how would you phrase that conversation with the mother to get her on board without making her feel guilty? Ponder that for your next clinical shift. Thanks so much for joining me for this high-yield explainer, and keep crushing those practice questions.